everyone. My name is Kendall Jamal Doucette. I am today's host for today's Real Talk, just time to remember and a time to act. It's a conversation around the International Overdose Awareness Day. And so before we get started today, I would like to just do a territory acknowledgement. So I would like to begin by acknowledging the indigenous peoples of all the lands that we are on today. And while we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment to responsibility in improving relationships between nations and to improving our own understanding of local indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and sacred territory of all the Inuit, Métis, and First Nations people that call this land home. So please join me in a moment of reflection to acknowledge the harms and mistakes of the past, and to consider how we can and we are in each our own way, trying to move forward in a spirit of reconciliation and collaboration. Thank you. So over the past several decades, popular attitudes towards addiction have undergone radical destigmatization. The addiction label has ballooned into common usage to include a list of behaviors such as overeating, gambling, shopping, kleptomania, and internet overuse and gaming. The concept of overdoing a behavior to the point of addiction has resonated with the public, even as many mental health professionals have cringed at the implications. So today's conversation is not about the decades spent in debate on whether addiction is a disease or a human choice. This conversation is about approaching addiction, approaching substance use in a different way. It's about starting a conversation that can guide people to healing and preventing the loss of a life. So I do want to invite my group of panelists to join me as we continue this conversation today. Welcome, everyone. Thanks for being here. So I will first begin by introducing Elita Flannery. So Elita is the founder of Epiphany Recovery and a sought-after recovery coach and companion. She completed her intervention training with Earl Hightower in 2018 and previously worked as the manager of community outreach for Greenstone Center for Recovery. As a certified addiction recovery coach, Elita serves as an accountability partner, helping recoverees to meet intent with action. She helps each individual to set their own goals, specific to their own strengths and challenges, and uses an empowerment approach to build their sense of self-worth and confidence. Having dedicated her life to the recovery and wellness field for almost a decade, Elita believes that the work she does isn't so much a job as it is a calling. As a recovery advocate and a person in long-term recovery herself, Elita has a personal and professional appreciation for the complex nature of addiction. She knows making the decision to enter a life in recovery is one that involves a great courage and understands the bravery required to take those first steps. She does this work to show others that there's a way out, that there's no shame in asking for help, and in fact, this may be one of the hardest things we ever do. So welcome, Elita. Thank you. And next we have Steve Lurie. So Steve recently retired as the executive director of the Canadian Mental Health Association Toronto branch, a post he's held since 1979. Steve has written and lectured extensively on mental health policy issues. He was principal author of the Graham Report, so building community support for people, and conducted the 1992 snapshot of community mental health programs for the Ontario Ministry of Health and the Minimum Data Set Pilot Project in 1998, which established a common data set for reporting of client characteristics and outcomes in community and hospital-based mental health services. He served as a guest editor of the Canadian Journal of Community Mental Health Special Issue, Innovation in Community Mental Health, International Perspectives, and their recent special issues on Canada's mental health strategy. He's recently co-chaired the HQO Quality Standard on Schizophrenia Care in the Community, and currently is the co-chair of the Toronto Police Service Mental Health and Addictions Advisory Panel. Steve's an executive lead on the Toronto Supportive Housing Growth Plan, a project of the Wellesley Institute, CHMA, Toronto Alliance to End Homelessness, and the Toronto Supportive Housing Network. He has an appointment as a senior fellow at the Wellesley Institute, and he was recently appointed as co-chair of the Toronto Crisis Pilot Community Advisory Table. He was awarded the Canadian Mental Health Association's CM Hinks Award for National Leadership in Mental Health and the President's Award for Outstanding Contributions by Addictions and Mental Health Ontario, and was recently named to the Order of Canada for his contributions as leader, scholar, and advocate in 2016. In November 2017, he was honored by CAMH as one of Canada's difference makers in mental health and addictions. So welcome, Steve. Thanks for being here today. And finally, and not least, Cal. So Cal Bear, Vice President of Workforce Risk and Worker Wellbeing, Holmes and Murphy and Associates. He's worked 30 years as a health and safety and risk management professional dedicated to construction since 1996. Launched mental health and suicide prevention initiative in the construction industry in 2014 while working for asphalt producer and paving contractor in the Pacific Northwest. Serves with the National Action Alliance for Suicide Prevention since formation in 2010, and executive committee since 2016. He also serves on the Lived Experience Advisory Committee of the Suicide Prevention Resource Center and advisory groups for U-Turn Health and MindWise Innovations. Former member of Expert Advisory Group for Center for Workplace Mental Health, and has been recognized by Engineering News Record as a top 25 newsmaker for 2016. He's also the recipient of Mental Health Advisory for Industry by National Association of Home Builders in 2022. So thank you all for being here today for this very important conversation. So every community faces different challenges when it comes to drug use and overdose. There are several ways we can reduce overdose deaths collectively, and however, stigma around persons who engage in substances reduces community acceptance and also the viable options and effective strategies that we can employ. It's important that we increase the knowledge and understanding of these issues. So it's through learning more about drug use and addiction, we can create these safer places for individuals to find support and feel less alone. Addiction, overuse, and abuse of substance is a human response to someone that is struggling. And for many, that response to suffering is from unresolved pain. So as individuals, we can do our part to keep the conversation going and reduce the stigma by building awareness. So our hope is through today's conversations to provide that space for us to acknowledge our grief, to reflect and remember, and then also to have this important and very difficult conversation on reducing stigma. So I would like to just start today's conversation around gathering your thoughts around how has COVID-19 changed the mental health and overdose crisis? I'll start with you, Steve.
Well, I think most people know that the mental health and the addictions systems or non-systems were struggling prior to COVID. And the impact of COVID over the last 2.5 years has exacerbated strains on the system, particularly in relation to access to needed services. It's also compounded by its effects on population mental health. People experience more distress, more loneliness, more isolation, and that has continued even as COVID wanes. We don't quite know what the new normal is, and people are struggling with masking, not masking. Some people are becoming anxious as governments remove public health measures. Others get anxious because there are public health measures. People have not had the companionship they're used to in relation to going to work, although Zoom and platforms like this have efficiency. People miss the personal touch, and so there's lots more social isolation. And I think for people who are at risk of overdose, things have gotten even worse because people have not had access to safe injection sites or even community spaces where they can use drugs in a supervised way. More people are homeless, and there are at least as anecdotal evidence of a lot of increased overdose because people didn't have anywhere to go, didn't have anywhere to stay. So, and then I think the final thing I'd like to comment on is that COVID has had an impact on the workforce, as we all know, particularly in healthcare. People are burnt out. People have experienced COVID themselves, which makes them less available to do the work. And people are thinking, well, we're not sure how this is going to end. And as I said at the beginning, it was an under-resourced system to begin with. So these things have just piled on one after the other, and I think it's caused more population-based stress, and then also people acknowledged that as a result of the isolation and more time at home, people were drinking and likely using drugs more. So all these things have had a major effect due to COVID, and it'll be interesting to see whether these effects wane over time as COVID wanes.
Yeah, absolutely. How about you, Cal?
I think Steve nailed that. Very comprehensive response. A lot of those factors. Love that term, population mental health. We think about a lot of social determinants of health. We think about those comorbidities that substance use has in the overall ecosystem of well-being. The impact of COVID was far-reaching and deeply impactful on many individuals. I think it did create an urgency, which is beneficial. It could be a lasting silver lining, despite all the increased anxiety, the depression, that increased alcohol use. It made irrefutable proof or evidence that people are struggling and that there is a need for change. And it has forced workplaces to respond with empathy, to acknowledge that people are struggling and we need to meet them where they're at. I think Steve's point about medical system access being disrupted was huge. I think the issue of disruption for recovery meetings, as a risk professional, that was one of the immediate impacts COVID had, helping people in recovery find virtual meeting rooms. That was something I didn't feel super well prepared. It increased my stress. I think both US and Canada seeing increase in fentanyl. So the toxicity that contaminated drug supply has really driven this urgency around support. So I think, Steve, your response was very thorough, and just welcome the opportunity to hear from Elita as well.
Yeah, Cal, I think you touched on a really important point there as well in terms of the access. So like moving to virtual, and let's say if it was a space in which people were looking for support, we also have to take into account now, how do they access that if they don't have, let's say, the technology, and that becoming a barrier as well.
Yeah, it exposed an inequity that we probably underestimated previously.
Yeah.
And it was something that was really frustrating if someone didn't have internet access or was in a remote location and they needed that recovery support. And you can hear even the stress in my voice. It's taking me back to a couple of years ago, writing a toolbox talk to share with people virtual recovery meetings. Right. And I'll probably never forget the first 3 calls I had of individuals in long-term recovery. I'm not worried about myself. It's my brother who needs this support. Does he have access to the internet? No, he doesn't. Yeah. And another gentleman who just knew that his access was going to be cut off.
Right. And what that stirs up for them, right?
Oh,
it's almost like the safety net kind of being lost.
Yeah. Thank you, Kendall. Yeah.
Elita, how about you?
I think my 2 counterparts have both summarized exceptionally well. I don't know that there's much I can add, maybe just a bit of color commentary, right? I identify as a person in long-term recovery. For me, that means I haven't used a drug or had a drink in almost 10 years. And so that is, I mean, it continues to blow my mind. I do, as a recovery advocate, take exception to the idea of even, the word overdose. It is implicit that if we were just taking the right amount, we would be okay. And so, yes, we are undoubtedly facing an overdose crisis. The houseless population in this country, in Canada, has definitely been affected profoundly by their limited resources that so many of us take for granted. we've had this movement or seen this movement that, you know, the opposite of substance use disorder or addiction isn't necessarily recovery, it's connection. And so as Steve spoke to, you know, what we saw with COVID was this extreme isolation coast to coast, you know, around the world. And everyone's touched on this idea of recovery meetings or connection with others, peers, support, that had been by default dismantled. The other thing that COVID, I think, brought to light was families were now at home and hiding substance use or being a little sneaky about substance use wasn't as easy as many wanted or, you know, had it pre-COVID. And so there was definitely a light being shone on families and different family members and what they were doing in their private time at work or after work now was sort of in the home. And so it has been challenging on many different fronts: employers, healthcare, families, and even people who, you know, I know who had long-term stable recovery. The number of reoccurrences, clients that I work with who were really struggling or who had experienced reoccurrence was tremendous.
Yeah, thank you. You know, to kind of add, I guess, a little more personal touch in terms of our own experiences with this. How has the overdose crisis affected you personally? Your community? You know, Elita, if you'd like to start there.
Yeah. I mean, I can be professional, but I can also be human, right? I've lost a number of friends over COVID. I've lost when you sort of like get sober or enter recovery with a group of people. In my world, we kind of affectionately refer to that as a litter. It's sort of like, you know, we're learning to walk and we're learning to kind of like puppies, and you know, some of my litter mates aren't with us anymore. And this isn't just necessarily focusing on overdose, but also those who have suicided, and it's been devastating for me.
Thank you for sharing that.
Sorry for your losses, Elita. And I think that concept of grief, individual and collective, will be with us for a long time. And it's grief not just over the loss of individuals, but of our routines and that sense of normalcy. But when it's compounded with that human loss, that's really where that struggle has been. For me, I started a new job on March 16th of 2020. The next day is when most of the world went work from home. And fortunately, I was told, take care of people during COVID. And so the timing was remarkable. Probably couldn't have staged it any better. But I have a tendency of overworking, and I threw myself into my work. And I'm now just unraveling some of my own personal chaos that I created by helping others and needing to practice what I teach. I'm not a person in long-term recovery. I did experience generational substance abuse in our family. My parents talked to us about it, let us know that that was possible.
Mm-hmm.
One of my family members struggled with opioid overuse. Fortunately, no overdose. I tinkered myself in my teenage years in the late 1970s. And when I found purpose working in healthcare, I pulled away. And so I just, by the grace or a higher power, did not succumb to a true outright addiction. It made me very sensitive how fine that line was. And like Elita, this has been a calling for me to help others confront that stigma, to overcome. And that's what I've been doing nonstop during the pandemic, letting people know that help is available, that it's okay to not be okay, that we're better together and stronger. Help is available. And so I marvel at the work that Steve and Elita have done, and honored to be here today.
That's all good. Thank you.
You know, well, paradoxically, COVID hit 6 months prior to my retirement. So we moved from meeting together in person to virtual, and that had its both strengths and weaknesses. On the one hand, there's a certain efficiency in living on Zoom, but on the other hand, that personal connection that you have with colleagues was gone. So, a year and a half after my retirement, I haven't said goodbye personally to my team. And, we've had, furtive Zoom calls and stuff like that, and I'm still doing some work in the sector. But, there is a sense of loss in terms of not being able to connect with people who are close to you. On the other hand, I've been fortunate in that it did bring time for me to spend with my family. My wife's retired, and so we've developed a routine. I also felt that because I was being, sort of captured by Zoom, I had to develop a healthy exercise routine. So I took to making sure I walked. And paradoxically, even in urban Toronto, there are lots of really good areas like ravines that you can walk through and hike. And then in the winter, I've turned it into cross-country skiing, so that there's been a bit of a health promotion advantage to my COVID experience. At the same time, I do know that there's a tendency to want to drink more, and there's a tendency to do those things. So trying to make sure that I don't drink too much. I happen to like wine and beer, and I don't want to tip. And in my own family, my late mother had a major problem with alcohol, and also through improper medical care, was also on benzodiazepines at the same time. So we had some interesting close calls there. So I think those of us who have had it in our family need to be particularly vigilant. And the other thing that I think we need to attend to is what this does mean for our personal networks. A professor in Chicago did a study of homeless youth, and the $64,000 question is like, what's the most important thing you can give a homeless youth besides a home? And the answer is actually a phone and a data plan, because what Dr. Carnick's research found was that the homeless youth had very dense social networks that they connected with in terms of text messaging and stuff. Paradoxically, the big problem was they also were trying to text their therapists, and their therapists weren't available at the hours that they needed them. So that gets back to the first problem about availability, and then the impact of burnout and the impact of short staffing. So we're in a challenging environment. On the one hand, we need to leverage what we've learned in a positive way in terms of how to take better care of ourselves, how to exercise, how to use substances less. We also need to figure out how we leverage technology to connect with people. And for some people, that means reaching out to communities and people who haven't had the use of technology and actually coaching them on the use of technology, because there is the convenience factor of being able to get help on your phone. And here in Canada, we've been fortunate that both the provincial government and the federal government have added online resources, but many people are not able to use them because they don't have the bandwidth in their local communities, or they don't have the equipment, or they don't know how to use the equipment.
Yeah, absolutely. It creates a lot of challenges there. It's a way to connect, and at the same time, if you don't have it or don't have the right tools to actually engage with it, then it presents a bit of a barrier. So what do you think is a contributing factor to the stigma and discrimination that surrounds substance use? Cal, would you like to start there?
Yeah, there's a lot of complexity on this topic of stigma and stigma reduction. A personal level, shame is a form of self-stigma. I experience shame from the family upbringing I had. I experienced shame in sharing with people my story, even as I was helping others learn to tell their story. I was afraid if I shared that story, it would thwart what I believe needed to become a movement. And so I kind of sacrificed that part of myself, even though I'd shared with my family. I think this whole idea of stigma, really understanding what it is, it's invisible, but it's as real as a brick wall. It blocks light, which limits hope. It decreases access to support. And it is a barrier. It is a blockade. It keeps people from feeling that connection. It puts people in isolation, makes you feel rejected. I think it also is this shroud of secrecy. It's an elephant in the room. It doesn't get better if you don't address it. And the elephant left in the room just grows bigger and bigger. And the more it, quote, eats, the messier it becomes. And people need to understand it needs to be addressed in a healthy and respectful way. And there are ways of effectively stigmatizing. But I think the biggest thing I see in the workplace, a lot of times people will feel, hey, I don't care what people do on their own time as long as they show up for work.
Right.
Or until it becomes a problem and they're tardy or absent, or there's presenteeism or workplace injuries or other issues. We can deal with it more proactively. We can teach people that this is a illness, that there are supports available, that help in recovery and treatment are effective.
Yeah.
I tried to save Elita some really good lanes here as well.
Elita, yeah, if you would like to jump in.
Oh yeah, I love this. This is what I live for. I think the biggest contributing factor to stigma in my world is that there is this choice associated, right? I didn't put up my hand in grade 4 and say, when I grow up, I want to be a drug addict. I put up my hand and said, I want to be a ballerina, and yet here I find myself where I am, right? And what we know about people who have substance use disorders is that the executive functioning section of their brain, their prefrontal cortex, is offline, right? And so their brain, and I hate using this word, but it is in effect hijacked. And when we see these people who we think, oh, they're lazy, get a job, and it's sort of like, these are mothers and fathers and sisters and brothers and sons. And often too, when we speak about the workplace, right, like there are hundreds of thousands of people in this country who are, going to work with substance use disorders or substance misuse. And often the assumption is, if I go to HR to tell them I have a problem, I will be punished because I'm doing something wrong, right? And we've worked for so long to talk about these people as unwell people, not bad people, right? These are people who are suffering and who need help. And when we put up our hand and ask for help, often we are shamed, or we are punished, or we are, disciplined, if you will. And that veil and that shroud of secrecy, right? All of the platitudes and catchphrases, I hear myself saying them and I kind of hate it, right? But like, our secrets keep us sick. And so, stepping into the light and sort of pulling back the curtain and talking about it without shame and without stigma. I do think that there are a lot of celebrities that have lent their sort of, name and notoriety to breaking down the stigma. And that's great, and we applaud them. But the people who are struggling in the shadows are the ones likely who need most of our help.
Yeah, absolutely. Steve, how about you?
Well, I want to start on the positive side in terms of what we've learned about combating stigma, and then I'll go to the historical antecedents of but we're still in trouble. So, the Mental Health Commission found that contact with people in recovery really was a way to bust stigma, and not only in-person contact, but virtual contact. So we have a lot to do to sort of present recovery stories and talking about people like Alina, who can demonstrate, geez, I got through it. I can do this stuff. It brings confidence. that you are not alone. At the same time, the historical antecedent, going back to the Middle Ages, where in Germany there used to be these river ships that cruised the Rhine, and they would stop at villages, and the villagers would take their people who were halt, lame, or mentally ill, or developmentally delayed, and put them on these boats, and then the boats would sail down the Rhine. I guess they can't do it quite as easily today because the Rhine doesn't have much depth anymore, and they push them off. And so we have a history of excluding people. And then, there was the legacy of the asylums. And terrible things happened in the asylums to people, so that if you were in an asylum and then you got out, you'd been traumatized by virtue of having been in the asylum. And then, even after we closed the big asylums, the mental health and addictions system has not had the level of resources that other areas of healthcare have. So when money gets invested, less gets invested in mental health and addictions. And my colleagues in the addictions field will say, well, you guys are complaining about mental health spending, but boy, we're the poor cousin in addictions. So we have a very, very long legacy of trying to pretend the problem isn't there, or willfully ignoring it. And I think we have to do a lot more to, again, tell the stories and give examples of people who have overcome addiction and mental health issues. There are thousands of recovery stories. For example, the Mental Health Commission of Canada estimates that by the time we're 40, 50% of us will have experienced a mental health or addiction issue that is serious. So that's almost half the population. And then if we live to 90, which is a good possibility for many of us, 70% of us will. So it's not this few. In fact, most people struggle with these issues every single day, and if they don't, they know somebody who does. So some of this is really, as you're doing in this panel, opening up the conversation and saying, yeah, I mean, there are problems in the system, but the kind of work that Elita does and that Carl does, to help people connect and get the supports they need when they're in trouble, using the online or the phone-based supports that are available and that have been increased. That's and letting people know that actually recovery is possible. There is hope. There is care out there. There is support out there. That's what makes a difference in people's lives.
Absolutely. I love what you touched on in terms of the importance of seeing people that look like you and I in our communities, who represent hope and represent that this isn't something that will be a forever thing for you if you're in that space. So I think that's really important. And Elita, you touched on having celebrities kind of, I guess, carry the torch in that conversation. And it's also just as important, or even more, for people in our community to be highlighted for the conversation to happen. It's lovely. So we have the understanding that many people who develop substance use disorders can also be diagnosed with mental health problems as well, or vice versa. How, I guess, dealing with substance use, alcoholism, or drug addiction, how do you think, I guess, is it important to say that as we learn to tackle addiction, is it also important that we're having a conversation if we are also experiencing a mental health problem? So I guess I'll open that up to Steve. Yeah.
Yeah. Well, I think maybe the best way to shine a light on this is to refer to a study by Dr. Greg Brown, who's a psychologist in North Bay. And a number of years ago, he used a mental health screener that was used in the hospital system and administered it to inmates in the provincial jails. And I point out that in our provincial jails in Ontario, these are people who've committed offenses, and their sentence is 2 years less a day. So we're not talking about people who've committed serious offenses. And this was an all-male population generally. What he found was about 40% had substance use or mental health issues that that could be readily identified. But on top of that, what he found is that 50% of these people had been victims of abuse. 60% had observed it in their lifetimes, and this is the shocker. 28% were victims of childhood abuse. So we can't underestimate the effect of trauma on people in our population, and that bad stuff happens. And so we need to sort of take a population health approach. Some of the work that Dr. Dan Orford used to do, where in the school system, you didn't just identify the kids who were in trouble, but you worked with their families. And so we really need to promote, family health. And we need to make it possible for people to talk about their trauma. There's a movement now, at least in the mental health field, and I imagine it's also in addictions, to really focus on trauma-based care, creating safe space for people in terms of treatment and not being judgmental, and providing that range of supports. And I know that's a journey more than a destination. I know that CMHA as an organization has been doing this work to try and up our game at the staff level, for close to 10 years. And it's like that kid in the back of the car saying, "Are we there yet?" And you're the parent and you have to say no. But it involves, frontline training, manager training, dealing with vicarious trauma that people experience by virtue of the work they do, dealing with burnout. Again, and these things have been amplified with COVID. So it's complicated, but actually we know some of the solutions. I mean, we basically making sure that our services, the mental health services and the addiction services that are available, that are trauma informed, is a very, very important first step, creating that safe space for people, and then also developing the specialized services that may be required to help people overcome serious trauma.
Yeah, absolutely.
Kendall, if I could
Yes.
just add to Steve's point, this concept around trauma and addressing the emotional needs of employees in the aftermath of trauma is really critical. It's where we've had our greatest success in workplace mental health, is acknowledging that, recognizing it, leaning in, and then grabbing resources and not waiting for people to say, "Hey, I was affected," but doing so more contemporaneously. And I'm really excited about the acceptance that movement has had. It's critical incident debriefing or critical incident stress management. It has so many different names, but the reality is people used to say we're tough in these hardcore industries. People are recognizing no matter how tough we are, how conditioned we are, no matter how much prior trauma we've had, any additional exposure makes that problem worse. And so addressing it in real time is one of the most effective strategies for workplace mental health. And so I just compliment Steve for that response. I involve myself in organizations that are addressing that critical incident response and the trauma-informed care and support, and huge impact.
Yeah.
Kendall, can I just say one thing real quick?
Yeah,
I feel I'm like, oh, I got to say this. Yeah, like, Steve and Cal have both touched on trauma, right? And we have this phenomenal physician here in Canada, Gabor Mate, who I'm a tremendous fan, and he has dedicated his life really to helping a lot of folks who are in the darkness of their substance use on the sort of west coast of Canada. And he talks a lot about, although every individual who experiences trauma does not develop a substance use disorder, he has never met someone with a substance use disorder who has not experienced significant trauma. And for so many of us, I'll speak from an I perspective. We grew up in homes where addiction was present. And for so many of us as well, we promised ourselves that we would never turn into our parents. here we are, right? And so Steve touched on that, and so much of this, with the Indigenous population here in Canada, and the idea of intergenerational trauma, like I believe wholeheartedly that also exists in the substance use disorder field very, very prolifically. And so when we are looking at the family unit, right, and we are looking at trauma, it is not only the individual who is sort of shackled by their drug of choice, it is also the family who has become very unwell and who also has been traumatized with the loss and the grief of that family member that they are experiencing, even though they may still be here with us, right?
Yeah. It almost becomes like a normalized environment in which you're in. So how do you get the perspective to step back and see it for what it is? Right? It's a big challenge. Cal, did you want to say something there?
Only to the extent that's what's really exciting again about the workplace. Looking at employee health benefit plans gives us an opportunity to address that whole, not just the individual, but the ripple effect through our family and the dependents. And that's what really excites me about the work that I'm doing and cross-border through the International Foundation of Employee Benefit Plans, Canadian and US. Many of the statistics that Steve referenced line up very well, US and Canada, prevalence of mental health, the prevalence of substance use disorders. But I'm seeing this international collaboration of individuals through those employee health plans saying we can bring support to big populations. And that's how we're going to get this seismic shift in mental health and substance use disorder, leveraging those critical masses that historically we didn't talk about this in the workplace. It was more taboo. And the last element, lived experience, all three of us have referenced that as panelists. It's the most powerful potion that I see, not only for stigma reduction, but breaking down barriers to care. And just to, again, applaud the work that Steve and Elita have done. It's motivating and inspiring for me to hear other examples.
Just picking up on both Cal and Alita's point, the notion of peer support is very critical to this. I mean, there's a long history in the substance use addictions field of like beginning with Alcoholics Anonymous, and then but the notion of gathering with your peers and saying, I'm here today, it's me, and getting that peer support, and then having a mentor. And we've also seen in mental health the value of not only peer support for people with lived experience, but also working with families to create family support, because a family who's gone through this can coach somebody else who's experiencing it now. So it's really bringing both the professional knowledge that we have, increasing accessibility to services and supports, but also making sure we include in that, as Cal said, and as Elita has represented, the notion of lived experience and helping people make those connections.
Yeah, absolutely. And hearing that also is like the importance of letting the people know that, or whoever are the touch points, to also include them in the healing or in the process. And it's also speaking to the idea, and Elita, you spoke to this earlier, about that individual who's engaging in a substance, they also have other identities. So they're not just a person engaging in a substance, they might be a mother or a sister, and all of these have socially impacting, experiences, right? So it's important to look at the whole individual holistically. Why do you think there's a comorbidity between substance use disorders and mental illnesses?
I'll just speak from super personal experience. I'm with my people, right? Like I take it lightly, and in mixed company, people think it's often a little uncomfortable. So I'm a person who identifies as someone in long-term recovery. I'm also in recovery from an eating disorder. I'm also in recovery or working through my complex PTSD from extensive sexual trauma. And I say all those things very blatantly I also qualify as a neurodivergent, and you know, all of those great, like it's like I wear so many hats. And when I first got sober, my eating disorder went through the roof. And for me, I have a friend who talks about spaceships, right? And so like my coping mechanism were substances, and that worked for me. That wasn't my problem, it was my solution, right? And then it stopped working. And so then you get rid of my solution, which is drugs and alcohol, and where do I go next, right? It's sort of like that whack-a-mole.
It's a void.
And I dove into the spaceship that takes me out of me, which was the eating disorder. And so the comorbidity is of course so much more complex than that. But often in inpatient treatment, we see different co-occurring disorders where one is sort of squashed or stifled, the other flares up. And affectionately, we refer to, you know, you've got 3 garbage cans that are on fire and you've got 2 lids. And so, you know, you're going to put out these 2, and the other flares up. Yeah. That was my personal experience. And often too, when, for me, someone with very pronounced ADHD, when I found drugs and alcohol, that was beautiful for me because it kind of calmed me down, you know? And so every person is unique, and every person is every individual is different. But so often, especially in inpatient treatment, we also find a number of people who are undiagnosed with mental health, you know, disorders that have gone untreated for so long. And then it almost becomes like, well, of course, when you found drugs and alcohol, this helped you.
Mm-hmm.
One really quick comment, Elita, I'm going to love that analogy of the 3 trash cans and 2 lids. That is such a vivid description of what many people are describing, but they don't have a way to articulate that. And I just wanted to compliment you for that. That second part, it's sad when people share, this was undiagnosed until my 40s or 50s. So much quality of life has been impacted, and you want to let that person know that help is available. But I think it's why we need to continue to break down those barriers to care. When you look at gender, sexual identity, race, there's so many statistics that we could share. We have to do better. Both societies can do better. I think acknowledging it is one thing, but really teaching people what are some of those best practices. And Canada has been ahead in many areas on mental health. We lean very heavily on your psychological safety standard. We look very closely at the work your Canadian Mental Health Association has done. There's many people that are leaders in this space. And on substance misuse and substance use disorders, I think more cross-border collaboration would be very effective. Unfortunately, our overdose and death rate has been higher than yours for a longer time period. We need to shed what hasn't worked and really move into what does work. And that peer support is one of those strategies. Giving people access to more resources on a more timely basis, not letting people wait till they hit rock bottom. That does not work. People lose their jobs, they lose their family, they lose support, they lose their dignity. You can't rebuild something from nothing. We have to lean in and hit people where they're at and avoid that stigma and give them multiple paths to recovery. That is one challenge that I see that we haven't talked about today that is creating that urgency in my own work of saying we have to amplify this part of the message or we will lose another 108,000 lives in the US this year and next year.
Yeah, well, just to pick up on Cal's point, and you know, we really do need to focus on what's evidence-based practice in mental health and addiction. And for almost 20 years, there's been a bit of a denial that you need to have a concurrent disorder strategy. You need to treat both issues simultaneously. There's lots of stories that probably people know about where they went for their mental health treatment and that was withdrawn because they were using substances, or they went for their substance use treatment and they couldn't get it because they had mental health issues. And certainly the evidence is pretty incontrovertible using cognitive behavioral therapy and stages of change, groups. That's the stuff that works, and it means that we need to make sure that our helping professionals aren't doing this, that they actually are thinking about integrated treatment and integrated supports, because if you have a failing, and I think it's fair to say that currently the systems out there are failing because concurrent disorder treatment isn't ubiquitous. I remember a number of years ago, I was working for the provincial government as the coordinator of mental health and addictions, and we had done a lot of work on getting new money for a concurrent disorder strategy that was supposed to roll out across the province. And then, fiscal restraint hit. And what did they cut? They cut the concurrent disorder strategy. And 20 years later, it still hasn't been fully implemented. So I think, it's really important that we, shine a light on systems need to acknowledge that concurrent disorders are more prevalent than we wish they were. According to the AMA, 50% of people with severe mental illness have substance use issues. 37% of alcohol users and 53% of drug abusers have at least one mental illness. So those are the facts on the ground. And we have to acknowledge that, treatment won't work unless you acknowledge those facts and then help people deal with them, and then use what has been learned about effective approaches to reducing the harms of substance use and helping people cope with their mental illness. And that does require an integrated treatment approach. It requires the use of groups for people that build on what we've learned through AA and other self-help groups. So I think that if we're going to move forward, job number one is acknowledging the stigma, and then job number two is doing the right thing.
Thank you. So we're winding down here, and I just wanted to kind of touch on another question in terms of what resources or what assets we actually have in the community to effect change. I just want to give you some space to think about or speak on what is important moving forward.
Well, maybe I'll begin. From a system perspective. There's this wonderful British television show called Yes Minister, which talks about life in the civil service in the 90s in the UK, and they coined the phrase the Law of Inverse Relevance. And the Law of Inverse Relevance says the more we talk about something, the less we intend to do about it. And so I think we need to make sure that effective action on mental health and addictions doesn't fall victim to the Law of Inverse Relevance, and that does require the things we've talked about in terms of upping our game around what is effective treatment in mental health and addictions. But it also requires us standing back and recognizing there's a public health approach to this as well. We need to have safe injection sites. We need to have safe supply. And, what British Columbia has begun to do in terms of decriminalizing use of drugs other than cannabis, that should be ubiquitous in both our countries, because that will remove the focus from law enforcement to treatment and care, and it will encourage people to say, look, I'm having an issue and I'm not worried about getting busted and going to jail for this. I actually need help, and it will certainly allow better focus for services that are working with homeless populations who are at risk of substance use. So, and again, we saw with the COVID pandemic that there was a big increase in deaths, in overdose deaths, and that was because things like safe injection sites, things like safe supply weren't available. And so we need, in addition to upping our treatment game, we need to take a public health approach to this.
Yeah, absolutely.
I'm going to come back, Steve, not only that public health approach, but using those employee health benefit plans gives us the opportunity for that critical mass. I look at the comorbidities in employee wellness and well-being. A study of 22 million lives, Milliman, international actuarial firm, they looked at high-risk claimants, and it was 10% of people driving 70% of the healthcare spend. 5% were driving 43%, and those were the behavioral health subgroup. So the problem is well known, it's well documented, but we have too many people ignoring the resources that exist. So Kendall, your comment about what assets do we have? We have governments that are well funded, we have technology, we have modern medicine, but we're not embracing new strategies. Public health has some of it. Workplace risk management, safety, health, wellness has part of it. We need to explore what is working and universally apply some of those best practices. The biggest asset we have, I think, is the tenacity and the persistence. People who have survived this illness are going to be the people who can be champions for change, and I think driving that peer support network. One of the groups that I partner with is called U-Turn Health. They have a digital platform for substance misuse treatment and peer coaching. And I'm seeing, again, irrefutable proof that that's having an impact on breaking down those barriers, giving people access to care. Employers are waiting for someone else to solve the problem. We can all do our part to meet people where they're at. We can't just sign a drug-free workplace pledge. We can't just do drug testing and think the problem's going to go away. We need to treat proactively employees, as Steve said earlier, employees, managers, supervisors, and all workers and families about substance use disorder and the available supports. Lastly, I think this idea around recovery-friendly workplaces is a movement that I've been researching and leaning into and seeing traction. And that's where you're taking the people with lived experience and doing something practical to embrace this as a workforce development initiative. So that's a lot, but those are the things that I think we can leverage for greater gain and for the greater good and to save lives.
Yeah, I agree. Elita, do you want to?
I mean, I'm just going to kind of go a little grassroots here. Specifically in the province that I live in Ontario, the toxic supply across the country, across North America, has been prevalent, and that there are testing kits, right? So there are safer ways to use. For many provinces now, with your health card, you can go into most pharmacies and get a naloxone kit, right? So there are some sort of grassroots pieces that we can put into safer use. And I do think it, Steve and Cal have spoken about it. Education does not equal transformation, right? Like if that was the case, we'd all just learn and be changed individuals and go on our merry way. And that's just not the case. But for me, what does equal that transformation piece is the application, right? And so like when we actually see what we're talking about, I think a lot of people are really great at saying, this is the money where, I don't want to get into government stuff, but this is the money that we're allocating here. And it's like, man, do a ride along with the street team for a night.
Right.
Just hang out in the trenches for a little bit and see what's actually going on out there. And then, your legislation and your programming may have a different angle, or you may have a different appreciation for what we're actually bumping up against.
Absolutely. Thank you. So we have reached the 60-minute mark, and so I just wanted to say thank you so much to all of you for joining today. and just sharing your experiences, your thoughts, and they're so valuable. So thank you very much. All right. And thank you for the folks joining us at home. We will be joining you next time with another Real Talk, and we will keep these conversations going. And please just take a moment on August 31st. It's the International Overdose Awareness Day. Take some time to just be in your thoughts and sit with the importance of what that day is about. Thank you, and take care.